It's been a minute. I love the
Sharon,
shirt.
I know you've been running around. I have been a little bit too. So,
Have you?
yep.
What have you been up to?
I did a little Wall Street update. Went up to New York this week, and everybody wants to know WTF is going to happen.
Yeah. So yeah, give me the latest on that. So it's the big beautiful bill, and within that, there's like Medicaid stuff. There's
Yes,
like kind of ICRA stuff too,
there's
right?
extra stuff. There's exchange stuff. There's yes, but a lot of the things just the bill took a major hit yesterday or the day before because to get into the reconciliation process, the provisions have to be primarily budgetary. And guess what? The parliamentarian said that a bunch of the key items were not primarily budgetary. They were major policy decisions too. So
Oh,
that's what has everyone scrambling around now in the midst of, a few other things happening like Israel, Iran, and all that.
oh yeah. Oh my gosh.
How are you doing?
Yeah. I haven't even begun to all of like the news cycle stuff going on. I just haven't even been paying attention to it
That's,
because I'm fully heads down on so we have the hospitology value-based care retreat in the fall, trying to
yeah.
do like speaker
I'm
stuff
sorry,
for
I
that.
took you away that a long planned trip. So I would have probably wanted to join you guys, but that looked really great.
Yeah, no worries. Next time for sure. So far so good on the traction and people who are signed up and so
Good.
forth. So um now I'm just trying to make sure the programming is good and all that
Yep.
kind of stuff. So I'm not the best with logistics. So
Well, I'm
uh,
sure there's folks that will pitch in with you and for you,
yeah, for
but
sure. I think we have a few more. Did we have a few more people pop in? Yeah. Ryan and Summers, they're coming
Yep.
in.
I'll
There he
there
is.
you go.
Okay. No, I got him.
Thank you.
Thanks, Ollie. Jim, I was thinking more about just what you briefly mentioned via email, just on kind of, the format of this. Would love to kind of brainstorm live with you real quick on like just because I do feel like I, promoted and put it out there and maybe the format is could be changed to be more value add, like you were saying, like interview an expert, like AMA type thing. What do you think, like an office hours type thing, workshop, a panel?
Well,
Like, what
no,
do you
I
think?
just think if we had a sort of a topic identified, and maybe we had a couple of different people with different perspective, either I don't mean opposing perspectives, but different lens on a pending issue. It can't. It's I don't know how I don't remember how frequent it is. It couldn't be all maybe every 2 weeks or every month or something like that. It might just pull in and we could get some input from the broader community on, what type of topics they'd be interested in over the next quarter or say, and
Yeah, yeah, for sure.
I
The
want
audience.
to, do a little homework on it and, help with some ideas going forward. Anyway, because
Cool.
I think it's a good,
Yeah, yeah, that sounds good. I think there's some good topics in mind for that. And hey, Rahan, I see you just jumped on. I think you're on mute, but hopefully we'll have a few more people trickle in as we get started. This is being recorded for like community members as well, so they'll be able to kind of access it later on. And
Blake, it might be interesting to ask people like, what would be a good time, day and week, day and time of day for something like this? Is this a good time or is there an alternative?
it's a good point. Yeah, because I know one time we did one after hours. I don't remember if that did better or worse.
I don't know.
But yeah, we could play around with that and try like Tuesday evening or
Or
during the work
morning
week,
time or whatever. Yeah, I
like a
mean,
lunch and learn type thing or something.
yeah,
Raihan, I'm actually curious, based on your perspective of doing VEs, virtual events, also, like, is there a time you find that works best?
Yeah, I like two slots. The lunchtime 12 to 1, and then the after hours happy hour slot, let's say 6 to 7. Now that can get hard with families who have
Yep.
children, but here in New York, I do all of my in-person events at the 6 to 8 p.m. slot. We have light bites, beverages on a replacement for dinner. But if you're scheduling a month in advance, it's reasonable to host at that time. I completely avoid morning time. I do think Friday afternoon is also great, Blake. Lots of folks are checking out more. They're looking for something engaging. So like Friday, 3 p.m., 4 p.m. It's also a good time.
Yeah, maybe we think about shifting it later Friday, Jim, or like, I don't know, maybe people are checked out by
Sure.
then. It probably makes sense to just poll and see, hey, one, what format do you want? And two, when do you want it? So I'll think about that.
Time zones too are an issue a bit, I guess, right?
Yeah, that's true. Just a little bit.
Yeah.
Anyway, Ryan, thanks for coming on. Like this is very informal. And like I mentioned, like many community members kind of check this after the facts, like as a recording, and we'll be happy to kind of leverage our discussion as like future kind of newsletter content and those sorts of things as well. So, appreciate you hopping on last minute. It's we're toying around with the format like you've been hearing. And Jake, I see you're on the line as well. Good to see you. How are you doing?
Good to see you, Blake. Doing well.
Sweet. Okay, I think that we can go ahead and get started and hop right into it. Raihan, do you want to go ahead and give yourself a brief introduction? We can kind of go from there. Oh, and we're frozen.
Yeah, happy to. So, fruity exterior city
Hey, Raihan, you're coming in super choppy.
and internal medicine physician.
Is he coming in super choppy for you guys?
Yes.
Okay.
How is
Yeah,
it now?
So he can he'll try to rejoin. Yeah, he just said he's having some network issues. No worries. Yeah, I can go over the agenda for today real quick. Obviously this is an interactive session. Hoping for more people to come on later. We had about 12 registrants or so hopefully a few more people jump on. But yeah, so Raihan's going to be talking about all things kind of AI and value-based care. He'll give an intro, hopefully once he kind of rejoins. And then from there, lots of interesting stuff this month and over the past couple months. The biggest kind of hospital and health system event being Ascension acquiring AmSurge officially. AmSurge being a large-scaled ASC platform. And then some fundraising announcements that I think are interesting, along with a couple of IPOs in the first half, and then a bunch of other notable stuff. Like Jim, we were talking about the big beautiful bill, and
Yes.
the AMA released some physician employment numbers, which I went over in the newsletter. The GLP-1 compounding fiasco. So we'll kind of get into all of that. But Raihan, I see you're back. I know you're having some network issues, so no worries. But why don't you try again to give your intro? We'll go from there.
Sorry, are you here? Are you able to see me, Blake?
Yes, we can see you now.
Okay.
Yeah, you're
Okay,
coming
perfect.
in.
Okay. You can hear me okay?
Yep,
Okay.
loud and clear.
So sorry about that. Well, thanks
No worries.
for dealing with the issues. So Raihan Faruqi, based here in New York City. I'm an internal medicine physician by training. I've worked at a variety of health tech startups as an operator and an advisor in the last 10 years, mostly in the early stage space. So kind of pre-seed through Series B, going kind of selling into health systems, hospitals, outpatient practices, and health plans. A variety of companies in the AI-powered B2B SaaS space, in care delivery, telemedicine, and remote monitoring. Currently serve as head of clinical partnerships at Guaranteed Health. We're a value-based end-of-life care company. We sell into health plans, specifically Medicare Advantage, along with very large provider groups, and are now kind of getting into BDC contracts with ACOs. Some are affiliated with hospitals. Many are kind of very large networks, IPAs, CINs, and outpatient practices. And then on the side, I run my own boutique consultancy called Connectify Health, where I work with very early stage companies. I help them with fundraising, with customer introductions, go-to-market strategy, and then clinical product strategy.
Awesome. Sweet. Well, you obviously have, storied career so far, both on a medical side, but also on, early stage and then in value-based care. And, you recently hosted a value-based care, kind of AI value-based care, webinar. How about we kind of, start there? What were kind of some of the key takeaways, you learned from that? And along with kind of like your own beliefs in this space, like what's kind of going on today with AI and value-based care, and what's kind of the state of things?
Yes, so I think there's a couple of things. I think as a whole, there's a dissonance between what entrepreneurs are building and what enterprise customers are asking for, especially with AI. So I'll give a great example. When you speak with executives at health systems and hospitals, oftentimes a top priority at the board meeting is, employee and clinician retention, right? It's the hair on fire problem.
Mm-hmm.
When you speak, and that's where folks have budget, they're looking to spend on solutions, workforce augmentation, helping to recruit and retain. When you speak with entrepreneurs, when you ask many of them, hey, is this problem even on your radar? They're like, nope.
Mm.
It's not something that they understand as a problem to be solved. What they'll say is, hey, I'm building a tool that's looking for a customer, right? So it's very product focused. It's not kind of business value focused. Folks will say, hey, I'm building an AI voice. And I'm like, cool. What solution does it provide? What's the bottom or top line? So there's that big dissonance, right? And I think I kind of fall in the middle of that space because I see incredible engineers, folks who have worked in innovation at providers, who now see this incredible AI revolution. It's very easy to use a large language model off the shelf and then really build whatever you want, front office, back office, and specific areas like voice have really taken off. But I think the problem, and I think we kind of got into this in the webinar, is that especially on the enterprise customer side, like sure, you can go sell into some small outpatient providers, but if you're meaningfully looking to scale, you're going to end up in like jumbo practices that are working with hospitals or have been bought by hospitals and health systems in some sense, right?
Mm-hmm.
And that is where legal, compliance, regulatory, implementation, where those barriers come into place very, very quickly. And those folks are like, I don't care about this. This is another widget. This is another point solution. We need to retain our staff. We need to decrease our labor cost, and we need to increase our revenue. And if you don't help us do one of those three things, we are not interested. So what I predict will happen is that there will be this Cambrian explosion of especially AI agent tools. And we're at the cusp right now, right? Where, these agents are autonomous bots. They are truly like digital workers who can by themselves do a whole bunch of things. But right now they're not really safe. They're not that reliable. They're a little bit janky. But I'm just seeing a ton of investors pouring a lot of money into these companies, and they're going to be selling into providers, front office, clinical operations, back office. They're going to be selling into health plans to help with prior auth, medical necessity review, denial management. They're going to be selling into pharma. And do those folks want this? Are they asking for it? TBD. So I think that's what I'm seeing kind of on the agent space. And then before agents, of course, we still have this, generative AI hype, right? Post chat GPT, folks, see a lot of opportunity with, patient education, obviously with ambient scribing, but other areas that have not fully implemented the potential, like, patient summarization of charts. We've seen a ton happening in the coding, billing, revenue cycle management space, but there's still a lot of white space with generative AI. But there's still a very questionable ROI, again, on the buyer side, right? If you're not super top line, bottom line focused, and if you're not a top 3 or 4 priority, you're not going to get implemented, right? It's a nice to have. It's not a need to have at the current moment. So I think that's where I'm seeing there is a little bit of this tension, but there certainly is a lot of curiosity amongst C-suite. I speak with a lot of CMIOs, CIOs, CMOs, and CDTOs at fairly large hospitals here in New York City. And these are some of the leading institutions in the country. They have already implemented a variety of AI platforms internally, but you know what? They're actually not buying or white labeling, they're building internally. So here we have Memorial Sloan Kettering, one of the top cancer hospitals in the world. We had HSS Hospital for Special Surgery, one of the top orthopedic hospitals in the world. They've got like hundreds of internal AI projects happening, and they're building. They actually have their own teams of software engineers and developers and program managers. They are not really contracting with external vendors as much. So again, there's obviously the haves and the have-nots. So where the haves have budget, they have, and they're doing just, they're building internally wherever their priorities are. So they're in a little bit of a different echelon, but then you obviously have health systems here like Mount Sinai, New York Presbyterian, which is Columbia, Cornell, Northwell, and, Blake, these are, 4 of like the top 30 highest margin, right? Health systems.
Doing quite well.
Doing quite well. And, several do have internal teams, but several are partnering with a variety of early and mid-stage companies. But, they're partnering in administrative areas and on all the predictable places: coding, billing, revenue cycle management. If they're doing VBC, it's automating care gaps, risk adjustment. If it's going to be on the, kind of care delivery side, it's, again, how are we decreasing revenue leakage, right? How are we doing referral management better, care navigation better? But it's all still serving the goal of bringing patients into the mothership, right? I'm really still not seeing anything drastically different where the presence of these tools is now causing the priorities to shift, right? It's not like these centers are opening their own, wellness and longevity clinics. Like, that's not happening, right?
Right.
Yeah.
So you say, do you mind if I ask a question?
Go for sure.
You say it's primarily on sort of improving the sort of, and I don't mean this in a negative way, like the efficiency of the operation, or, freeing up resources to be doing more routine tasks so that headspace or that amount of resource can be put on something greater, sort of ROI, that kind of thing?
Yeah, I can give you a good example, James. So we've obviously seen this incredible interest in revenue cycle management, especially AI-based companies. Typically, traditionally, providers and health systems would have armies of people, physical people, who are coding, right? It's coders and billers. Every year, you have this massive book. It's a physical book of CPT codes. But in the digital era, where now all this stuff is online,
right?
And when charts can be in real time analyzed for the right diagnosis, there's opportunities for upcoding and for misdiagnosis, and
Yeah.
All that can be done in real time. Why is there the need for people to be doing that?
Yeah.
Right. So now you enter this tool that actually starts to replace a part of that coder and biller. We're not saying you're replacing the entire function, but maybe you're starting with 10% and going to a third. So now the value of the tool is not just efficiency, James, we're talking about labor replacement.
Right. Right. You can
And
do
so some
less. You can do the same process with less people, fewer people.
correct, but that's a direct financial ROI of, hey, you
There
can
is.
now hire less
Mhm.
people.
Exactly.
You can have bottom line improvement that then
Those
improves
are-
your
yeah.
margin.
Right.
Yeah. Yeah. So like if you're
Well, you
you're a
could
CFO,
redeploy some of that. In theory, you
Yeah.
could redeploy a portion of that saved resource to some
Yes.
high ROI opportunity.
Well, I think I'll be frank with you. I don't think the redeployment is happening. I think what in reality what's happening.
Oh, I agree. Conceptually, you could, but in the real world, no,
Yeah,
they want the savings,
No.
right?
You want you want margin improvement,
You
right?
bet.
That's what you want.
Yeah.
So that's where I'm seeing the intense interest in everything associated with revenue capture and then speed for revenue. And there's many different tools here, right? They're not all the same. There are some tools that are just working on denial management. There are some tools that are just really good at coding. There are other tools, right? They're just different. And then, so I think we'll see some consolidation there. On the other side, we're also seeing incredible interest in AI scribes, where you're able to transcribe a visit, whether it's in person or virtually, convert that via natural language processing into a structured SOAP note. That now saves 2 to 5 minutes per visit. That decreases pajama time. So docs are not going home and finishing their notes. That decreases administrative burden. That decreases burnout. But that's a soft clinical ROI, James, right? It's keeping your docs happy. It's bringing the joy back into medicine, but has it made you more money and decreased your cost? Only going to make you more money if now those docs can see more patients and bill more.
Right.
But paradoxically, that would actually make their that would actually make their satisfaction go down.
If you go from 20 minutes between appointments to 15, that's really not.
Yeah, you go from your panel,
Perspective.
5K panel to 15K.
Well, quick
Correct.
question on that, because don't you save
Yeah.
on turnover costs? So you're saving because your doctors aren't leaving and you're not spending a third of their salary to hire somebody to backfill.
And so when you look at companies like Abridge and Nabla and Nuance, and to your point, that is now what a lot of their marketing is shifting to, because their customers are looking increasingly, if they want to renew that contract year 2, year 3, it's like, hey, we need some financial ROI. And that's exactly what they're saying, that by having this tool, you will retain your docs. You won't have to spend money on recruiting future docs. That's exactly that. But that's TBD. We're going to have to see evidence and proof if that's actually the case.
Before
And then
before Augmetics was bought and went private, they had an investor presentation where they like claimed that their solution improved RVUs by like 1.5x or something like that, whatever it was. So I do think there was a shift in language there. And then the other shift I'm seeing, just like from the Abridge announcement, is they just announced a new product line or whatever, like a continuation of their product to where they're like moving into RCM and that documentation side. Are you kind of seeing that too, Ryan?
Yeah, I am. So I think my big prediction will be that there's 2 things will happen. Because historically these have been separate companies. I'm building a scribe. I have an RCM tool.
Mm-hmm.
One has a financial ROI. One has a clinical and debatable financial ROI. You will see a lot of M&A between the two. So scribe buys RCM, or RCM by scribe, bidirectional. Or secondly, and we're already seeing this with Abridge and Nabla, their next products will creep into coding, billing, revenue cycle management, deploying Blake agentic tools.
I gotcha.
Exactly.
Yeah,
If
that
you
makes a lot
read
of sense.
if you read the press releases of both companies, that's what you see. That we are now no longer a scribe, right? We are now a end-to-end, clinician and administrative, pilot or assistant that will be deploying agentic tools and, coding capture, care gap closure. Again, revenue. It's all about revenue.
Yep.
Yeah.
So
I,
big
um,
subsets on the revenue on the RCM side, like you're saying.
to that
Correct,
point,
Correct.
Yeah.
to that point, Commure just announced their kind of agentic thing like
Correct.
yesterday. So as you know,
Exactly.
this is obviously the hottest space because I talk to Ian Shaquille fairly often, who was at Augmetics,
Yeah.
is at Commure now, and he's always called it ambient technology. He's never called it like an AI scribe. He's like, that's too narrow because like in his
Yeah.
view, he sees like, everybody kind of laughs at Commure as like the Olive 2.0, right, or whatever, because it's like, what do they actually do? But like what they're trying to do is like create this AI like infrastructure like layer,
Yeah.
right, essentially across the enterprise.
Yeah.
So I,
Yeah.
I agree with you.
And Blake, I think the parallel trend that's happening in value-based care. So let's set the stage. So you have ACOs, you have capitated practices in primary care, in nephrology, in oncology, and now in neurology. You have a variety of CMMI programs that are getting capitated payments, right? You have CKCC in nephrology, you have EOM in oncology, you have the guide program in dementia, so on and so forth.
Mm-hmm.
But again, top line is it's revenue. It's revenue and it's speed to revenue, which is why you've had all of these tools, and the sole value proposition is risk adjustment, which says, hey, let's look into your pool of patients that you are, contracting some risk-based contract. Let's ensure that you're accurately coding. Let's ensure that we're not missing any diagnoses, because guess what? The riskier your patients are, the more money you're going to get, because that's how the benchmarks are calculated. So you have this entire also like very parallel space in the BBC world where you have all these vendors. They just starting with like let's call an apple an apple. It's upcoding, right? Or properly coding. So I think that's very tangential to the kind of coded billing, coding RCM vendors who are selling into the fee-for-service space. They're completely parallel, which is why there's also been so much investment, Blake, in that space, right? Like Navina is a great example of a company that just, right? What's the platform? It's efficient chart review, accurate risk adjustment, right? And they've got some pretty big logos.
That the fee for service side.
I think
Is that in the fee for service?
some of the value-based care side.
On the value suite. Yeah. Okay.
Yeah, so Navina's like a co-pilot
Yeah.
for physicians, enablement platforms, those sorts of
Yeah.
things. Yeah, I mean,
Exactly.
The coding is going to run into the payers, public and private, though. Right?
But this is where
There's lots of
really
tools being developed, but it's the same problem with like, MA upcoding. Okay.
Correct.
Is this going to address that and fix that whole problem or no?
No. I mean, the only thing that's going to fix that is government and legislation.
Yeah.
But the interesting thing that will happen is that now realize that there's also a host of vendors that are selling into health plans.
Right. That's
That are
what I was
saying,
thinking. That's where I was going. Yeah.
we're going to help you do prior auth
You got it.
easier and better.
That.
Yeah.
If you're a health plan,
Well, I mean, we'll fix that, sure. But I'm actually looking at it the opposite lens, where again, if you're a plan and you're like, oh my goodness, I'm basically facing now this onslaught of tools with my VVC providers and my fee for service
Right.
providers.
Right.
And they're just using all this AI to now send all of these claims my way. Well, I'm now also going to contract with AI vendors
Right.
that are going to ensure, like, hey, is this, was this 5-second or 10-second AI coding real? So we're actually we're heading to this world. It's going to be the AI versus the AI on both sides.
Right. I was going to say dueling AI tool for the
Correct.
typical places where there's, Collaboration with conflict.
Correct. And then you're also going to have the AI voice agents on both sides. I've talked to several vendors that are saying, hey, health plan, we are going to actually replace some of your nurses and care managers who are doing chart review for utilization management. And leveraging voice, those agents are also going to call the docs. So imagine end to end, end to end. You're replacing a part of an FTE. It's the same value proposition that I said on the provider side, right? But then now imagine you're calling the provider, but the provider also has a voice agent that they've deployed. And now the voice AI agents are talking back and forth.
Sounds like a science fiction movie.
Can I ask
That's
a
science.
follow-up question on that?
Yeah.
Actually, so if you think about Gartner's hype cycle and where generative AI is, right, it's like starting to fall through the trough of disillusionment.
Sure.
Like how much, like where do we really think the plateau of productivity, I think is what they call it, is going to fall? Because really all of our framing and our projections of the future right now are based on a world where it's at the peak of the hype cycle, right? Because that's been our experience for the past year or two. So where do we really, like, where do you, as an expert in this space, really think that it's going to level out?
Yeah, I think that's a fantastic question. So I think voice is a really important space to watch. When you think about the friction that I'm sure all of us have had calling a provider and trying to schedule a visit, there's a lot of friction there that should not, I mean, come on, it's 2025, right? Doesn't make any sense. I see that being a space where I think for most providers, it is just such a no-brainer because it's such a sticky problem. And consumers are like, look, I'm like, you got to do better, right? The status quo just doesn't work. Where on the other side, when you think about voice AI or, I don't know, like care management or, like care plan compliance, we might see a lot of friction eventually from patients who are like, I don't want to talk to a bot. I want to talk to you. I understand that I can't talk to you all the time, but this bot feels really impersonal. I'm concerned about safety and privacy. You didn't disclose that this was a bot, right? So I think, again, we're going to see some productivity and then we're going to see some disillusionment, I think, based really on what the consumer's experience is. If any, I'm sure all of us have used some type of chatbot with Amazon or with Delta, right? And it's a variable experience. I'm sure some of us have been like, hey, this is great to solve my problem. Other times it's like, this is terrible. I just want to hop on the call with a real person. And I think that's what's going to happen in voice, right? We'll see this kind of variable experience, but it is happening. I mean, these call centers are completely being replaced by voice agents, completely. And that's where the funding is. That's where again, it's a big bottom line cost center for health systems and providers. So I think that's here to stay. And then I also do think ambient scribing is here to stay. I mean, ambient, if you talk to any clinician who's used it, they'll be like, this is magical. Yeah. And then if you speak with folks who've used it for 6, 9, 12 months, they're like, it's okay. Like, they kind of get used to it very quickly. Like, honestly, it's nice. I can get home and eat dinner with my family and it saved me 2 to 5 minutes. But honestly, there's other parts of my workflow that are a lot more time consuming than the documentation part.
They recalibrate their expectations.
So for example, I'll give you some areas which are actually really sticky. Chart triage, chart summarization, especially if you have really complex patients. Imagine you're 85, you have 5 chronic conditions, you have 9 medications, you've been to the ER 8 times. That patient costs $100,000 a year. Good luck getting the time of going through the recent images, the recent labs. You're looking for that discharge from 5 years. Like, you can't Google an EMR. It doesn't work like that. Yes, Epic has all this new tooling out. They had a bunch of, but like most clinicians are like, they're not using those things, right? It's very painful. And I think that is a awesome use case for a generative AI to actually drive a lot of time savings. But again, that becomes a clinical ROI, a soft clinical ROI, right? So cool. You've used this tool. CFO is like, all right, cool. I'll give you this tool. You can summarize your chart better, but can you see more patients?
Right.
Right. So I still think those top line realities will still remain where, these tools will be useful to patients. They'll be useful to clinicians. But at the end of the day, if you're not decreasing labor cost, if you're not decreasing some fixed cost, if you're not increasing revenue or code capture, what really will be the scale that some of these tools see? Like TV. So I hope that answered some of the questions.
Thanks. I appreciate it.
Yeah, it's interesting. And then, as you mentioned, kind of like those fixed costs, Ryan, in like talking specifically about like the payer side and in like value-based care, um, you're talking about massive premium dollars, right? And so like obviously you have like a large tranche of that that's like medical spend and like required medical spend. Then you have like this, when you're at scale, you have, the 50% that's admin and, a 1% or 4.5% improvement using some sort of AI, contact center, whatever it is, like the steady, like you were saying, replacement of FTE, like half an FTE over like your entire contact center, like that turns into material dollars at scale. And I think that's what we're seeing in both payers over time. And then also in health systems too, like HCA and Tenet specifically, just because, they're a little more of unicorns, but analysts were literally like bewildered by how low their labor costs were in Q1. Maybe 2020, but Q1 specifically. It was like 44% of rev, which is like insane for a hospital. Like most of the time you're seeing, especially on the nonprofit side, 55%.
That's right.
So like you said, it's like that's the biggest labor. That's the biggest cost.
Is it already having that impact?
So I think post-COVID, with all like the contract labor stuff and travel nursing fiasco, like a lot of health systems invested a ton into like retention efforts and like career advancement efforts. And HCA specifically, like they have like a vertically integrated kind of supply line with their college of nursing, which is like very, very smart. I don't know why more health systems don't like really do that same thing. But that along with like, I know there's a lot of things happening behind the scenes with like centralized nursing and like centralized monitoring and like virtual nursing and monitoring, like those sorts of things as well. And again, I don't know how much of it is just secular macro trend related to, hey, there was this huge wave of travel nursing during COVID, and now it's like everybody's settled down and they're just happy with where they are, and that's like the part of the cycle we're in. Or we're also using AI and technology to leverage like smarter patient monitoring observation rooms and like those sorts of things. So I think we'll kind of see maybe that play out over the next couple of years. But I just find that very interesting. Like labor for the big guys is like at an all-time low. I don't know.
Yeah.
Ronald, do you have any comments
to add
on
on that, Blake?
Yeah,
I do. And I think to add on that, the single largest cost center is labor. And this is where I think the unicorns, but also the folks who are low to negative margin, the pressure to adopt, especially agentic tools, is so tantalizing, right? Like if you're low and negative margin, that is the quickest way to improve margins, like point blank. And I think there's a real opportunity, Blake, especially with, entry level and mid-level clinical labor. So let me give you an example, right? So if you're an FQHC or if you're a rural hospital, right? What's the stat? A third are broke. Yeah, like hundreds. I mean, is this administration going to come save them? No.
I mean, they're cutting Medicaid, right? Isn't that what they're trying to do?
You can't recruit labor. Point blank.
Yeah.
So what do you do, right? What do you do? And so if you're like, hey, look, if I can deploy an agent to be a care coordinator, to be a dietitian, to do some of the lower acuity tasks of a nurse, that's material.
Yep.
That could actually help keep your lights on.
I was I was at an event in New York with a company, and they had a CIO there from a rural health system, rural hospital. Maybe it was like a 1 or 2 hospital system, and he had had a few at this point. And he was like, I want to be able to, like with technology, we're vetting like AI scribes. Like I want to be able to do the exact same thing from a behavioral standpoint, from an operating standpoint, and get paid more. Like that's literally what he said. He was like, I think I put that in the chat during the virtual event. But he literally was like, this like, I want the tech to obviously improve quality of life and all those sort of things, but I just I want as little lift as possible for the maximum results because that's what we're working with, limited
Yeah,
resources and
of
those sorts of
course.
thing. I'm like, I mean, yeah,
Of course.
wouldn't everybody want
I think
that?
he's talking about the revenue side. I mean, he's talking about the revenue side, Blake. But I think the larger problem in low resourced areas is labor. Like this is the elephant in the room. When you speak with, again, rural hospitals or rural clinics, like let's just be frank. Like Blake, you know me, I keep it spicy. People don't want to move there, and
Yeah.
people are leaving. There's very little incentive to stay.
But they don't want to go to New York City either. They
No,
want to go
they
somewhere in between.
They want to go somewhere where I think there's two things. It's I want to live somewhere where it's affordable, but I also want to be somewhere where there's a job,
Right.
right? And we've seen kind of remote work die out. So I think there's a lot of folks in these rural areas, and we've seen like traditional rural industries like farming, like pretty much die, right? I mean, they've been kind of bought up by these really big, they're becoming verticalized. So like even a lot of these independent mom and pop type businesses in rural America are dying. This is the
Yeah.
big issue. Like, how are you, if you're unable to recruit and retain clinical labor, right? We're talking about docs, nurses, but then also billers, receptionists, techs. What do we do? Is a bot better than nobody? Yeah, I think so.
Maybe sometimes. I don't think the answer is blanket yes. I mean, if your bot does more harm than not being seen at all, then that's just a huge liability. So no, I don't think it's a
Absolutely.
blanket yes.
Absolutely.
Maybe
And I think liability is, of course, the biggest elephant in the room. I mean, obviously do no harm, but are we already doing harm? Like, let's think about this. Are we already doing harm by not having labor there? I think that's actually the base.
Absolutely. Yes, absolutely. But I think the question is, do you give the patient the perception that they can get the service close by getting it from a bot versus having them drive to, I don't know, an hour, 2 hours away where they may actually get seen by a person? Like I would argue that in some cases, conveying to that patient that they could be seen locally by a not good solution is doing more harm than having the patient drive a long way.
Yeah. I think that's a discussion that needs to be had.
Yeah, that's interesting. I think that there's a lot of interesting things around rural health. And like you see year in and year out, like these hospitals are, they're either closing maternity wards or like they're, 40% are underwater on margin or whatever it is. I mean, I think that maybe there's a
Yep.
broader conversation to be had around like, is like keeping these hospitals afloat the best economic option here? Or is it like creating some sort of other network? And maybe there's like an opportunity for not AI, but just like some sort of carve out of technology or allowed regulation for these communities where there's like, shortage areas, whatever it is, to allow, I don't know, AI telehealth to diagnose, but low acuity stuff, or I don't know, whatever it is. I'm not a policy expert, but
Yeah.
um,
No, I totally agree, Blake. Like we actually need this parallel system for low and medium resourced populations that we currently don't have, right? Like the free market as is has failed those areas point blank. Point blank. So, but does that mean that government just comes in and tries to fund the construction of new providers? Maybe. Is there political appetite for that? No.
Yeah.
But I think to your point is really getting very creative around policy and reimbursement and thinking through what are the levers that we do have, right? We've got mobile, we've got virtual, we have kind of the flipped logistics model, right? I mean, there's this big there was this big push around at home. I mean, and we're seeing this a lot in rural places with specialty care, right? Where you have these command centers of 50 to 100 critical care doctors, ICU docs, you have, stroke specialists. You have all these specialists that are in like this Amazon type warehouse with just monitors, and they're actually now monitoring like 30 to 50 rural hospitals.
Wow.
Right. Like, but I think but now that works for specialty care. But now when you actually need a physical person in the home, or if you need somebody to physically go to a place, what do we do there? Right. So is it like just dispatching a bunch of trucks or vans to where you are? Yeah. I think that's the model that we actually have to invest in, because that economically is fine.
It's a simple answer.
Yeah.
Robots.
Yeah.
Robot care.
Yeah. Yeah.
No, but
But
I know.
but like, it's like, when you look at a large stretch of the nation, where I think, and to your point, the closest provider is an hour or two away. Well, guess what? Is that provider going to be there in a year or two?
Right.
Like, that's just a reality. So if they're not, and if that's going to be the future of the next 5 or 10 years, like, what does that mean about outcomes in those areas? I mean, it's terrible. But that means we need a new system. Like, I think to your
Even
point.
access.
Yeah. So I just read about a company in doing kind of last mile care, mission mobile medical, but I think there's like Homeward and other companies in that space.
Yep.
And gosh, I forgot what I was gonna say, but there's just thinking about the model differently is going to be needed for sure. I'll see if I can think about that thought again.
Yeah.
Anyway,
Sorry, I didn't want to interrupt, and so I just put it in the chat. But I do think that there's an in between the highly credentialed providers and AI or nothing. And if you aren't familiar with her work, Minnie Kalan, who's actually in Austin, Blake, has done really impressive work leveraging lay people and the phone, to improve chronic condition outcomes, right? It's like not even a virtual visit, it's just the phone.
Yeah. That's great. I totally agree, Anne. It's like we need this, like we need to upskill people. Again, like, people are looking for jobs. There are lay folks that we can upskill and train. And then there are also folks in the system that we just need to have be at the top of their license. Like EMTs can do more, dietitians can do more, nurses can do more, but that's also, do they get paid more? And how do we see and we've seen this battle play out with PAs and NPs versus MPs right now, right? As the PAs and NPs do more, they've kind of taken that. So there's this like turf battle in between. So.
I think there's another interesting trends in AI that kind of ties into this a little bit. I just think there's been a lot of talk about consumer in 2025, both from an AI perspective, but also companies becoming more, I guess, consumer friendly in a way, right? Like the former PillPack founders just founded General Medicine, which is like they're trying to create like this marketplace for like essentially like consumer based navigation for care services at like cash pay prices or the lowest possible shoppable price, like those sorts of things. Curious if you've seen anything on that front, Raihan, that's noteworthy, interesting.
Yeah.
Yeah.
Yeah. I mean, I think the other headwind is lack of price transparency.
Mm-hmm.
And I think that's where the general medicine play in their marketplace is different. And this is like a really difficult data problem, because as most of you know here, like nobody knows the price of anything. Because it's all, in hidden contracts between payers and providers.
Right.
But they're there. So it's leveraging APIs, leveraging AI, and this is what general medicine is doing in real time. How are you able to surface that information to consumers, like before the point of care, being like, hey, here's the visit, here's the procedure, here's the medication, this is how much it costs. Now it's up to you how you want to pay for it. I think it's just such a massive opportunity for companies to surface that information, and also can cause some downward pressure. Right.
Yeah, definitely.
Yeah.
As consumers kind of learn that they can look elsewhere,
Exactly.
those sorts of things.
Exactly. Consumers they don't know that you don't have to pay a bill from a provider. Like it's not a bill.
Yeah.
It's something that is just them trying to make as much money from you.
Yeah.
And even simple education, I was talking to this about my wife, and it just blew her mind. She's like, "Oh, I don't have to pay this?" I'm like, "No, no."
Yep.
Like, what justifies them charging 3 to 5x the cost of this thing? Like, and if you look at the back and forth, it's just a complete negotiation, right? It's like they charge you 5x the price, and then they get paid, 1x the price by the plan, and you're like, wait, but could they turn around and charge that to me? It's like, sure, but look, why would you pay it? It's not a real bill. It's just them. So, but I even like that and that education, but then having platforms that surface those things in real time, Blake, I think would be so powerful, for consumers. But again, I don't think the system at large has an incentive. I mean, the system at large wants to block that from happening. They don't want price transparency.
Yeah, they want network entrapment, patient entrapment, those sorts of things, especially on the health system side.
Of course.
On this same note, I want to ask you about consumerism, but also like in the context of like this longevity and kind of wellness surge we've seen lately.
Yeah.
I think maybe this is a good topic to end on.
Sure.
I have heard anecdotally, I haven't done any of like the longevity stuff yet. I probably will at some point, probably pretty soon. But I've heard it's just like, hey, a bunch of testing with like kind of a fancy wraparound and like a telehealth visit, more or less.
Yeah.
I just saw, Quest release kind of like this wholesale, like comprehensive testing package. So I'm more of the opinion that longevity in its current state will not continue, but it will kind of move back towards like a more kind of direct primary care, like concierge offering, because like you can go to your physician and pay cash pay. These are the same consumers, right? Paying cash pay on a longevity site versus DPC, right? And they're able to order the same tests and give you like more, continuity of care. So one, I guess my question is like, what's your take on like longevity as it sits today? And two, like, do you find that a more feasible future, or like, do you like what will it take for these current crop of companies to like sustain, I guess?
Yeah. I mean, there's a couple of things happening. I think the first thing is there's a massive dissatisfaction from relatively healthy consumers looking for an improved like health span experience. Like these are many like, there's a term called health span. Yeah. So, and I think why these terms are important, Blake, is that so if you have a chronic condition and you're seeking a specialist, like you're not a health span person, right?
Yep.
At the same time, that also doesn't mean you should not have that type of education and care, right? So I think both things are true, where a lot of the longevity market started with biohackers, the healthy and the wealthy, but it's also young people who are healthy for now, but they also understand that as I age in my 30s and 40s, if you're a young woman, it's, everything from PCOS to infertility to family planning to then like early perimenopause, right? For a lot of men in their 30s and 40s, right? It's like testosterone deficiency, it's metabolic issues, it's, creeping up cholesterol levels. Like, even though you are not diagnosed with a condition, right? You're kind of slowing down. And I think that is where a lot of the longevity space is looking to capture that market. Because it's unaddressed by primary care. If you don't have a problem, if you don't have a fire, don't come to me. So folks are like, I have problems every day in my life, even though I'm not a diagnosed patient. I don't feel well. I'm not, I don't look great. Like, where do I go? And so that's the market that longevity is looking to capture. So it's absolutely there. But again, to your point, what's the product? Yeah, it's a bunch of lab tests. It's like some slick UI wrapper that explains what those results mean. And then if you're lucky, it's a telehealth visit. But there's a lot of curiosity around alternative medicine. And I'm not endorsing any of these things, but peptides are all the rage right now in that community. If you just go on TikTok or Instagram, obviously because of the GLP-1 craze and very wide now awareness amongst consumers. But there's a whole host of peptides that are now being marketed and branded, and some need a prescription, some can be compounded, and some. But just I think we need to get curious around why this movement is happening. Like, it didn't come out of nowhere, right? There's this intense dissatisfaction with accessing the current system, and like people, like, they want more involvement from someone. It's like a once a year annual wellness visit or a physical is not enough. I need more.
Yeah.
So if I'm investing a lot in working out and eating well, I want somebody else to like really kind of think about my long-term health, which I think is fair. Is fair.
No, I agree. It's just interesting because I struggle to see a future where like this longevity, it's almost like you're seeing the stratification of primary care, right? Where it's like you have like Medicare Advantage and like senior, like Oak Street Healths or whatever, and then you have like nurse practitioners or whatever, like Medicaid, they get whatever is left over, and then you have like this worried well, which is great. It's like replacing like the the commercial primary care, where like primary care has kind of been absorbed. I don't know. It's kind of like I struggle to see a future where like they somehow don't converge and like
I think it's interesting. Like, I think anecdotally speaking, I don't know if it replaces. Why I say that is, again, if you're like this kind of 25 to 40 category that a lot of these longevity health spend wellness companies are targeting, like, you're not going to primary care anyway.
Sure.
You're not, and you're not going to a walk-in clinic, right? This was, right, CVS, Walmart, Village MD's thesis, and guess what? They were wrong.
Yeah.
They just don't show up. They just don't go.
And that's like the thesis, right? Is like primary care as a standalone business does not really work anymore. Like, it's not economically feasible for the most part, unless you just do a really good job or like you're an independent and like you're crushing. So like, in my opinion, like it's either gonna be, hey, you need to have this high dollar service to remain afloat, or it's gonna be absorbed into multi-specialty or like specialized primary care, like call it like headache or whatever it is, like these service lines. So that I don't know. I just think we're kind of seeing this morphage of primary care.
I
primary care broken.
Who would you say, Jim?
I was saying, so it feels to me like the current primary care, the historical primary care model is broken.
Yeah, I mean, they just don't get paid enough.
They don't get paid. Yeah, that's the problem.
I know, but I just mean, even it's hard to find good primary care, at least in the big cities, anywhere. Even, I mean, when I was in middle America, it's not easy to find a practice that has people doing primary care that much anymore, unless you go to a boutique and you pay, whatever.
Correct. Yeah.
What's the quote about like every system is perfectly designed to get the results that it gets? Right? Like primary care is broken or isn't financially feasible because of the ecosystem in which it was designed and has to function today, which doesn't incentivize people to keep you healthy, right? So they get reimbursed like pennies.
Right.
And it's hard to make money that way.
Yeah. But it creates a gap, and in terms of
big time
being, I mean, access, we talking about access for years and years and years, for decades.
Yeah. And my hope is that this technology and all of this testing that's like expensive today, like the cost goes down over time, that it's more accessible, with the implementation of AI or whatever that looks like. So.
Yeah, I mean, a lot of these issues, again, they're
already, right? Because like Quest and LabCorp are coming out with their like corollaries to whatever function is offering you for $500, right? Like Quest or LabCorp just came out and said it was gonna be like 80.
Is it really only 80? Well, I'm gonna do that.
For
That
what?
might be wrong.
What are they
Don't quote me on the dollar amount, but it was less than function health.
But that's interesting though. Like it's talking about function specifically. That's why they bought Ezra, right? Like so they have like this higher dollar offering, and can tie into like actual technology. Where like I think Ezra is maybe like leasing the space, but like an MRI is not easy to replace wholesale, right? Like so those kinds of things.
Yeah.
I just think it's a very interesting space. I don't necessarily have a conclusion, but
Yeah. It's Blake, it's definitely not a fad. I think, I've definitely done some deep dives into folks who are building there. Like there is just this massive underground interest in longevity right now that I didn't realize how big it was. And I just tried to be really curious, like where is this coming from? And if you kind of think about it, like D2C telehealth is a good corollary. And it's like, okay, well, you're just prescribing Viagra, you're just prescribing acne medication. Like, what's so special about that? I think what's just so special is that, again, yes, these are lower acuity areas, but this is what occupies folks who don't have a chronic condition. Like, it's your thing, right?
Yeah.
It's your problem. And if you have a company that comes and addresses that with slick marketing, good access, a good branded experience, like that makes a difference. I think
totally agree.
that's where longevity is capitalizing on right now, or in a more meaningful way, right? Now, whether it's going to be clinically valid or not, I mean, I'm not here to impart judgment, but it certainly isn't going away, especially when you think about now the ecosystem that's being built out, right? These things are not happening in silos. You have this incredible now interest around food and nutrition, right?
Yep.
Like food is medicine. You also have, again, this like new age fitness culture, right? Where now gyms and saunas are the new place where people build community. You have a decrease in the number of folks going out and drinking alcohol at bars. Like these things are connected. Yeah, James, here in New York City, bars are struggling. They're struggling because young people are like, I don't need to do that anymore to meet people. I can go to a sauna. I can get some self-care. These are all connected trends.
Yeah.
Right? You're going to yoga, you're going to Pilates. Like that culture is not going away anywhere. And it's only getting
I think there was a Seinfeld episode about that many years ago.
And you've got all the new millennial moms who really care about, their kids' toxicity and stuff like that. Like, I have a 22-month-old, and my wife is just like crazy about like what's in this, is this fabric toxic, whatever it is. People care a lot about those things if they're not focused on diabetes or whatever.
And this is also tied in with, again, the democratization of information through Google, but now large language models. Like if you really think about this now, it's like 10, 15, 20 years ago, if you had some rare issue, or if you were looking for a community, like you couldn't find really resources or education. But now, like it doesn't matter what you have this big community digitally that's out there. There's in-person meetups happening, and leveraging a large language model, you're able to very quickly get pretty accurate information. Right. So that a lot of that, like in addition to be something, are causing a lot of this upward pressure. So do I think that impacts primary care? Sure. Like, does it impact like OB/GYN care? Sure. But still, like, again, these are the folks who are not seeking that care to begin with. Right. So I don't necessarily, Blake, see it as a loss for like commercially insured providers. I don't. Because guess what? Like if I'm going to Hims and Hers for D2C telehealth, and I actually have an issue, like I'm not going to go to Hims. I'm going to go to a primary care doctor, right? Like the buck stops somewhere. Like I spoke to the CEOs of one of these longevity companies recently. I'm like, look, if I have a chronic issue and I get something serious, he's like, well, great. We're going to refer you to somebody. We're going to be like, hey, this is where our AI doctor ends, and where more serious, higher acuity clinical care begins. They're limited, but they're not meant to be a replacement. I think they're meant to be. They're filling a gap that exists.
It's an add to what was there before, right? Versus a replace. Is if I'm hearing you.
Yeah,
Yeah,
that's
that's
just so interesting. And Summers, thanks for dropping that link. Here's like the PDF of everything they offer. You said it's like over 1,000 tests or something like that. Can you imagine getting every single one of these? That's crazy.
But they have to see like some sort of right either competition from function or just some opportunity in the market to capture all of the interest in the people who don't have direct relationships with providers and are coming to them for like random testing. It's like let's capture them for their wellness and longevity jobs to be done too.
Yeah, no, 100%. Yeah, like I said, I just think that there's a big opportunity here for like DPC, maybe like some sort of DPC network or something to take advantage of this like sale, like offer it way cheaper. I don't know.
I totally agree with that. I also think this is a huge area for women's health to plug into. I think, unfortunately, when you look at the state of startups, a lot of companies are direct to consumer. If they try to go B2B2C and sell into an employer or health plan, it's historically been very difficult unless you're in fertility, maternity, perimenopause, like, again, some higher cost areas that employers and health plans really care about, right? Everything else has been really hard because the point solution is too small, the cost impact is too small, but these are areas of incredible clinical need. They're unmet clinical need, right? That's where I see a lot of potential and overlap with longevity, actually, is women's health.
That makes a lot of sense. Yeah, I think that's a good part. I mean, so someone like Maven might have a big opportunity there, or similar kind of company.
Yeah.
But yeah, anyway, Ryan, we're about 7 minutes over, so I don't want to take too much more of your time. But I think everyone else has dropped other than Jim. Jim, my one holdout. Appreciate you. But thanks so much for the time today. I think this is a really awesome discussion, actually. Yeah.
Sure.
Yeah, so this will be a recording, and I'll probably leverage some of this for a newsletter at some point, just because I think longevity is so interesting, and then everything else we talked about is super timely too. So have a good rest of your weekend, and we'll be in touch.
Thanks for having me on. Take care, guys.
Yes.
Thank you. It was great. Great discussion.